All right, I guess we can get started here. Um, Welcome, everyone. Thanks for attending this webinar. This is part of Sandata's webinar series. Today, we're going to talk about provider integrity in Medicaid home personal care services. My name is Kirit Pandit. I am Vice President Analytics at Sandata. So this is a short 30-minute presentation. I'm going to try and leave at least 5 minutes at the end for Q&A. And we will do Q&A once the presentation is over. So a real quick look at what I'm going to be presenting. Initially, I'm going to talk a little bit about Sandata, who we are, what we do. Quickly get into electronic visit verification, or EVV, which is at the heart of identifying potential fraud, waste, and abuse. And then I'm going to give a couple of examples of the type of fraud. Because it's a short presentation, I don't have too much time to get into a lot of detail, but my hope is that I leave you with enough information, and if there are any follow-up questions, we can certainly take those after the webinar. So who is Sandata? So we are based in New York. We are the leading provider of home care software and technology. We have been in business for over 45 years. We work with both payers and providers to provide patients a really good quality of care in their home setting. Our solutions are designed for both home care and for IDD, and we work with state payers, we work with MCOs and plans, and we also work with individual provider agencies. So a quick look at our solutions that span the entire workflow of home health visits, starting with the order manager, which is an application used by plans to distribute cases to the provider agencies. Now, once a provider agency receives the attributed patient, then they go ahead and schedule that home health visit. And then the caregiver visits the patient's home, typically using a mobile phone. And that is used to capture the visit information, such as the start time, the end time, the type of service provided, etc. That information that is captured is then used for electronic visit verification, or EVV, and I'm going to talk about that in just a minute. Now, once the visits are captured, they are available on the Sandata provider portal. So individual agencies, for example, can log in and they can look at all of their visits today or historical. Next, all the provider visits are then aggregated in the aggregator portal, which is another Sandata product, where the state or the plan can log in and they can now look at all of the aggregated visit information. Once the visits are verified, they are then routed to the claims validation and the claims adjudication process. And finally, we have a very comprehensive analytics and business intelligence solution that spans the entire workflow that you can use to generate very detailed visits and charts. So a quick look at how big Sandata is. So in the home personal care services, we are by far the most dominant vendor in the United States. So you can see here, we process in 2022, for example, last year, we processed 175 million annual visits across 18,000 provider agencies in 40 different states that came from 2.2 million caregivers who were serving 2.7 million patients. Okay, and like I said, we've been in business for over 40 years. So we have um, really a large database of visits that we can use to mine information and run all sorts of analytics. So let's talk a little bit about electronic visit verification. So this was mandated in the 21st Century Cures Act, which was passed in 2016. And it's a large, the 21st Century Cures Act covers a lot of different things, but specific to home health, it mandates that all providers need to electronically verify their home care visits. So there are 6 data attributes that need to be provided in order for this verification to happen. Okay, so the first one is the type of service provided. The second is who is the individual that is receiving the service. The third is the date. The fourth is the location. Fifth is the caregiver information, right? Who is providing the service. And the sixth is the start and the end time, also known as check-in and check-out time. So if we have all these attributes available, then we can run them through the verification engine and make sure that it's all very consistent. And if it is, then we can electronically verify the visit as a proper visit that is sort of verified, and now it can go through into the further downstream activities. Now, the act was actually passed in 2016, and at the time they required all states to be compliant by January 1 of 2023, but then that was actually pushed out by 1 year. So as of now, that deadline is January 1st of next year. A quick look at Medicaid home personal care services. So we all know home health, right? But there are 2 parts of home health. And the part that we specialize in is home personal care services, which really involve activities of daily living, bathing, eating, hygiene, dressing, etc. These are covered through Medicaid and many times through Medicaid waiver programs. And just to give you an idea, in 2022, the entire home health spend in the United States was $118 billion, of which the home personal care services spend was 20 billion. And just in the last 15 years or so, it has grown from 3 billion to 20 billion. So you can get a sense of how quickly that part of the home health services has grown. So nationwide, there are about 4 million or so caregivers, typically earning minimum hour wages. The median is $15 per hour. And therein lies the biggest challenge, which is nationwide, we are seeing workforce shortages. A lot of the caregivers are leaving to pursue other jobs that are paying them more than minimum wages. The other trends that we see is a continued increase in home health spend and also the home personal care spend, primarily because of the demographic shift, right? We just have a lot more population that is aging, and also the need for companion services, which is typically for senior citizens who live alone. And these services provide companionship for certain portions of the day. We are seeing a huge increase in that part of the business as well. Okay. So, so where does fraud come in, right? So whenever you have an industry that grows this quickly, it does attract fraudsters, unfortunately. And this is a press release that came out literally 2 weeks back, something like that, from Missouri. And you can read the yellow highlighted portions of this I'm not going to read through the whole thing. I'll just pause here for maybe 20 seconds and let you read that. So you can see here that just in this one case, right, there was anywhere from $500,000 to $1.5 million in potential fraud, for which the Missouri Medicaid program was built. Um, and again, what is interesting here is billing for times when this caregiver was actually traveling elsewhere in the country, or to foreign locations. Um, this happens a lot, and um, I'll talk about that again in the example that I'm going to give you. But you can get a sense here that this is just one data point from Missouri, and you can sort of multiply that across many caregivers, and then across all the 50 states in the United States, plus District of Columbia and other places where you've got a large number of beneficiaries, and you can start to get an idea of the magnitude of the problem here. And just the thumb rule that is used um, is that there is anywhere from 5 to 10% fraud. So if in last year, if there was $124 billion that was billed to Medicaid nationwide for home health, then you know there could be anywhere from 10 to $12 billion worth of fraud. That's sort of the magnitude of the problem here. So it's pretty huge. So here is an example of how electronic visit verification information can be used to identify suspected fraud cases, right? And again, keep in mind the fact that EVV is mandated. Most states now are EVV compliant. Most providers are EVV compliant. So this is not a futuristic thing. This is something that is already in place. So how can we actually use this effectively to start identifying suspected visits? So here's an example. Now the data here that I'm going to show you is not real data. It is made up data, but the actual example is real, right? So here's an example. Okay, so this is the EVV information or the visit information that we got, and you can see the 6 attributes. Type of service, which is the what. You can see that T1019 is the code. You can see the whom and the who, right? Who received the service, who rendered the service. You can see the location, which was Duffy Avenue in Hicksville, New York. You can see the date of service, which was 12th Feb. And the start and the end times, which are typically known as call-in time and call-out time, was initially recorded at a little after 11 a.m. And the call-out time was around 3:45 p.m. Okay, so roughly 4 hours and 45 minutes was the duration of this particular visit. Notice that the call out time was later adjusted to 5:15 p.m. Okay, so an extra hour and a half was added to the duration of the session later, either by the coordinator or by the caregiver. In some cases, in some states, they don't allow the caregiver to actually make changes, but the coordinator can come in and make changes later. Okay, now, because these visits are captured typically on a mobile phone, we also collect the geolocations of where the call-in and the call-out was made from. So in this case, the call-in latitude and longitude information and the call-out latitude, longitude information was available. And for those who are not familiar with these geocodes, if you look at this, you'll probably think that, well, there's hardly any difference here between the latitude and the longitude, right? It's almost like a third or fourth decimal difference. And so you would think that, okay, it's not a big deal. Maybe, you know, maybe the call in time was recorded when the caregiver was at the front door, and the call out time was recorded when the caregiver was in the living room or something like that, right? Well, it turns out that those third decimal differences, when mapped on uh, a Google map, for example, gets what happens is it results in a totally different address. So in this case, it turns out that the call in time, the call in and the call out correspond to two different addresses entirely. Okay. And if you actually take these and you map those out on a Google map, you will see that that the call out time was actually made across the street, and it actually happens to be a Dunkin' Donuts. So what must have happened is that the caregiver actually left the member's house early, um, and then drove over to Dunkin's, and then checked out from there, um, and then later on went back into the visit record and then updated the call out time and added another hour and a half. Okay, um, so these are the sort of um, anomalies that we can find just based on the information that we have, and especially where we have the geocodes and the authorizations and some of these attributes that we can you know try and see if they all make sense or whether there are anomalies of this type. Here is another example, even more glaring. Um, and you can see here that the green circle, which is centered right a little bit below New York City, is actually Washington, D.C. So the green circle corresponds to members or beneficiaries living in the District of Columbia. And the green circles correspond to the caregivers who apparently were uh, rendering services to these beneficiaries and were supposed to be at their homes. And you can see in this case that there were services that were captured where the member was in London, where the caregiver was in London, in some cases in Paris, and in some cases in Tokyo. So this was a situation where the caregiver was actually traveling internationally and was uh, falsifying the information, was actually clocking in and clocking out, uh, and somehow assuming that they would not get caught. Okay. So a few examples of the type of um, fraud, waste, abuse reports that we are focusing on. Um, and I don't want to go through each of these, but the ones that really are very prevalent, very common, are the ones on the top left under the caregiver section. So you can see, caregivers who are logging in more than 16 or in some cases even 24 hours per day. And in many states, there are labor laws that require a certain cap on the number of hours that a caregiver can work continuously. So in these cases, um, I think that there is a cross between what is being recorded in EVV and what those laws allow. Another common one is uh, caregivers who are seeing multiple clients at the same time, and the clients are in two physically different locations. Um, we also see caregivers doing a lot of manual visit verifications. So we saw an example where the call out time was changed. So that would um, be an example of a manually adjusted visit, and then that goes through a different visit verification process. So caregivers who constantly do that that's a pattern that we need to investigate. The fourth one is where clock in and clock out GPS distance is beyond a certain level. So this is the example that I gave, and also the example where the member was in uh, Washington DC and the caregiver was sitting in London or Paris. Um, and the last one there that you see under that section is a potential match with either the federal or the state sanctions list. Uh, so this is an example where a caregiver or a provider is listed on the exclusion or the sanction list, and we want to alert the agency or the plan, you know, uh, as soon as we find that out. So those are some of the more popular ones, but you can sort of go through these. These are all the different reports that we're trying to pull together. The one thing that I will say here is that traditionally, most fraud, waste, abuse has been done post claims. Okay, so typically it's also known as pay and chase, right? So you make a payment, and then later you realize that there's enough evidence to suggest that there is fraud, and then you try to recover that amount. That is typically the way fraud, waste, and abuse has been done. What we are trying to do here is proactively identify suspected visits or potential visits even before they go to claims. So by flagging these upstream earlier in the information flow, um, we can avoid the cost of paying the claim as opposed to making the payment and then recovering that, right? So the whole idea behind this approach is avoidance as opposed to recovery. Okay. A few examples that I pulled directly from our fraud, waste, abuse dashboard. So this is a heat map that shows employee conflicts. Again, an employee conflict is where the employee is, um, there's evidence that the employee is with two different members at the same time in two different locations. So this is a heat map that shows the days on which we had more incidents more of these sort of incidents. Um, and then here is one that shows authorization violations. So these are visits that were made even though the authorization had expired. Okay, so just two examples that I wanted to show you. So um, what you can do, so this is something that I want all of you to think about, because I think you know some of you are working for plans, some of you maybe at the state level, some of you maybe with providers. But what you can do is have a conversation internally about how the Sandata EVV can potentially be helped in identification of fraud, waste, abuse, especially the avoidance versus the recovery part, which is very important. Um, Look at what you do currently, which department drives this, what data are you currently using, and whether the EVV data, if it's currently not used, can be useful in this process. Um, and then also start thinking about your goals, because like I said, a lot of the fraud, waste, abuse so far has been done post claims. So it's mostly recovery based. And hopefully what you can do now is start thinking about avoidance versus recovery. Um, and then finally, who would it be most beneficial uh, to exchange this information with, right? So if you can just ask yourself these questions, I think you can start making some headway within your organization on how you can use this information. And then finally, if there is interest in knowing more, any details that you need, feel free to contact us. There is a QR code here. You will be getting this presentation from our marketing department. So feel free to contact us. There is a link at the bottom here as well that you can use and send us your questions. So with that, I will stop here and Sammy or April, if one of you two can, if there are any questions, I'll be happy to answer those right now.
Okay, there are a couple of questions. So one is the GPS distance allowed still at 1,000 feet?
Good question. So that really depends from state to state, from plan to plan. Um, there are, in fact, there are some programs where we are asked to actually turn off the GPS exception. So for multiple reasons, they are not currently using the GPS information at all. So I can't answer that question except to say that it differs from state to state.
Okay. Next question is, when we do start of care, it takes about 1.3 hours to do the paperwork. Nurses cannot spend that time in the patient's home. Shouldn't that be exempt?
Great question. Yeah, to me that does seem to make sense. And I don't know where the states are on this question. Unfortunately, I can only give you my opinion on this. It does make sense to include some of the overhead as part of the session.
Okay. And for this one, we might want to go back to the heat map slide just for reference, but what do the different colors of the heat map reveal about behaviors, i.e. multiple visits? And how about the second graph with exceeding authorizations?
So on the top map, the darker the color, the more the more visits we have flagged that where there are employee conflicts. And the way the heat map can be used is, and of course these are drillable cards here. So if I actually click on one of these days, it is going to take me and show me all the visits where there is an overlap. The same caregiver but two different clients, and there is an overlap. So it's going to show me all of those details. But the whole idea of presenting it as a heat map is, for example, if there is a pattern where there is a caregiver, for example, who works, let's say, Mondays, Wednesdays, and Fridays, and we see particular agencies or particular caregivers that are featured in all these reports, then that can be used to further strengthen your argument that maybe there is something going on here, right? Or in some cases, what happens is, if you're looking at a very recent past, like last week, you may not really have all the visits still in the system, and so you don't see a darker color there. But over time, when you keep looking at the same, and this dashboard actually refreshes at least once a day, but when you start looking at it several weeks later, and you realize that now a lot of those days have turned dark, then that means that there are manually adjusted visits that were not there earlier. Now they have come in, and so there's a lot of different ways in which you can infer the data. So that's about the top one. And on the bottom one, the red bars indicate where the authorization was exceeded. So the longer the red bar, the more the authorization has been violated. That's sort of the way it is. And I'm hiding the actual name of the caregiver, but there is a caregiver associated with each of these bars. So when you click on it, it will show you who the caregiver is, and it will show you the amount that has exceeded the authorization.
Okay, thank you. And
Sure.
on the heat map related topic, do providers have access to heat maps or other analytics currently?
Yes, some of them do. And so again, if you are working for a provider or a plan, and if you have interest, please contact us. But yes, the answer is, we do have plans and providers and states that currently have some level of access to some of these cards.
Okay. And one last question. Will our state Medicaid organization have the most current information on the GPS limits?
I think so. I think so. I think that I can consult internally with some of the experts on EVV. We have a few folks who are experts, but I can certainly consult them, and then either me or uh, Sammy, one of us can actually would be happy to answer that for you.
Yep, we can send a follow-up.
Yeah.
Okay, it looks like we're at time.
Yeah.
If we did not answer, there's a couple of questions in here that we didn't answer, so we'll get back to people that we missed.
Yeah, absolutely. We'll be happy to do that. All right. I think that's it. Thank you for everyone for attending. I hope this was beneficial. And again, don't hesitate to reach out to us for any more information. Thanks.